time limit.
I will, Dr. President. Thank you very much. I'd like to thank Dr. Ganga, Dr. Rupesh, and Dr. Namrata Sharma for having me here. I'm Tarjani, and I'm going to talk about orbital reconstructions. What is new? I do not have any financial disclosures to make. You will see full face photographs of some of my patients for which we have the consent. Now, I'd briefly like to take you through the objectives of my presentation today. We'll be talking in short about orbital fractures, the way we classify them, the surgical planning, the hidden incisions that are used these days for improved aesthetics, image guidance in orbital reconstruction, the role of 3D printing, the implants used for orbital fracture repair, the need for multidisciplinary care, understanding the complications of orbital fracture repair, and the lessons I have learned along this journey. I will summarize these with 10 pointers. To begin with, I just wanted to share that this is my perspective. It's not all correct or all wrong. It's not all good or all bad. And everybody can have their own perspective of treating orbital trauma. What I'm going to share with you is the sort of protocol that we follow here. Now, when we look at the role of the orbit, it is to protect the eyeball. It provides a cushion around the eyeball, and there are several facial buttress systems which are present to give the facial skeleton its vertical height, its horizontal height, as well as to provide the bony support for mastication. These buttress systems and suture lines are what are involved in orbital trauma, especially one which goes panfacial. Typically, when we talk about orbital fractures, we have the zygomaticofacial maxillary component of fractures. We also have the nasoethmoid fractures, which are more along the central skeleton. You have the blow-in or blow-out fractures, which typically involve the floor of the orbit. This is a blow-out fracture where you see that the contents are prolapsing outwards towards the maxillary sinus, versus a blow-in fracture where you see the contents prolapsing towards the inferior rectus muscle of the orbit. You also have certain sinister ones like the white-eyed blowout fracture where you do not see any signs of trauma at all. But when you image, out that the inferior rectus muscle is actually entrapped in the maxillary sinus, and this child is more likely to have restriction of elevation as well as depression. There are certain complex situations, especially in the Asian subcontinent, where road traffic accidents are taking over as the number one cause of trauma, who are more likely to see panfacial trauma such as this, where management sort of tends to become complex and is multidisciplinary. When we look at surgical planning for orbital fractures, there is a nomogram to divide the fractures into those that require immediate care versus those that can be operated in the next couple of weeks, and those where late repair would not be difficult or would not be counterproductive to the outcome. When you have any child with a white-eyed blowout fracture, as you see over here, where muscle movement is restricted, in such patients or in those who have a gross enophthalmos or hypoglobus and those with a non-resolving oculocardiac reflex, you go ahead with immediate reconstruction. Versus this, patients who are borderline have about, a relatively moderate to large size fracture, say more than 50% of the floor, say more than 2 walls involved, and where diplopia and enophthalmos are the main concerns, you can possibly wait for the first 2 weeks to let the periorbital edema settle down so that you can grade the outcome of your repair better on table. And there are certain fractures where you might not see a lot of periocular signs and symptoms. You just want to wait for stabilization to see if the diplopia improves, whether the diplopia was due to nerve injury, or if it doesn't improve, then consider these patients for a late repair. When we talk at fracture repair, we've moved on to a better aesthetic outcome in terms of using hidden incisions. And there are 3 specific incisions that I'd like to mention over here, especially for us to treat the medial wall and the roof as well as the floor. The first one is the eyelid crease incision, where you can hide the incision very beautifully within the natural eyelid crease and still expose the entire roof and the lateral wall area. You could alternatively use the floor incision, which is transconjunctival, and again does not require incising the skin in the subciliary area and producing lower eyelid complications. And the third one is your transcaruncular incision, popularized by Goldberg, that actually allows you access to the entire medial wall, especially in those complex ones where there is a bony fragment impinging on the optic nerve posteriorly, or where you have associated medial wall fractures. The fourth point I'd like to talk about is the innovation that the image guided system has brought in. And this truly revolutionary sense that you can have intraoperative guidance of where exactly you are placing your plate for fracture correction, so that you have an excellent outcome in reduction of enophthalmos, as well as avoid complications such as the muscle being shifted from its position due to the plate. So this particular tool is very similar to the GPS that you have on your mobile phone or on your car's global positioning system. And it helps you navigate into the orbit, especially because the orbit is a pyramidal structure and visualization behind the eyeball is limited due to the anatomy. Navigation system helps you in giving that extra boost of precision and accuracy to orbital reconstruction. This is a video of a patient who has a left orbital fracture. Since we are a little short on time, I'm going to run through certain segments. You can see the obvious enophthalmos on the left-hand side, and this is a fracture which has been repaired using the navigation technology. Here is the coronal scan where you're able to see a fracture of the floor and the medial wall. The posteromedial strut was involved. And on a forced ductions test, you will see that the left side is slightly restricted when compared to the right. In such patients, we ask for a particular protocol of CT scan image, which is loaded onto the navigation machine. The defect size can be configured by going through successive coronal scans from anterior to posterior to exactly delineate the fractured segment. Once this part has been done, you go ahead with your routine surgery of transconjunctival incision, placement of your release of all the tissues from the orbit, and yeah, that's the transconjunctival incision, and the tissues are peeled out from the maxillary sinus, and eventually the plate has been placed inside. Once the plate has been placed inside, you can again use your navigation probe. This is the navigation probe in action to tell you whether the posterior part of the plate is actually sitting on the posterior ledge and giving you a sort of correction in enophthalmos or reduction of the fracture as you would desire. Just to show you a couple of snapshots, so this is another patient who has undergone a navigational guidance fracture repair. Additional things that you can do with this toy are to mirror image the CT scan, flip it over onto the affected side as you see the red and the white. So this is the mirrored image, and eventually see if your plate is sitting on the mirrored image or not. So this sort of precision is what image guidance can give you. The next advance that I would like to briefly touch upon is 3D printing and its role in orbital reconstructions. 3D printing essentially is a technique by which the facial skeleton is printed, and it is used to either configure patient-specific implants or to understand the morphology of the fracture in extremely complex cases. So what you do over here is load the patient's 2D scans onto the machine and convert it, you crop the area, you convert it to a 3D scan. This is done by a readily available software. Crop the area of your interest and send it to a printer, which can print the facial skeleton. This is a very basic level 3D printer, which utilizes a plastic material to sort of print the facial skeleton. And this is the printing process. It involves two materials, one which gives you the facial skeleton, and second is the support material. The support material dissolves when you put it in a water bath, and it will eventually give you the patient's actual size orbital floor in its real-time dimension for you to configure patient-specific implants in these kind of situations. This is an example where the defect is configured on a 3D printed skull, and the area of the defect is sent to a printer to generate a very patient-specific implant that treats just the area of the fracture. For orbital floor fractures that also involve the rim, this is extremely useful, and you can generate specific implants that help you in correction of not only the floor but also the orbital rim. Speaking shortly about implants, we've moved on from using a lot of bone grafts to primarily using titanium, and there's a whole variety of titanium available. But the one thing that I'd like to mention is the 3D titanium plate, which comes pre-configured to help you correct the medial wall as well as floor fractures. And it comes in several sizes. And based on your intraoperative calculation, you can use these 3D plates. Bone grafts, especially calvarial bone grafts, dissected from the skull bone, still play a role in certain extensive fractures where you'd have lost the orbital rim and you want to reconstruct the orbital rim, or where you have additional segments to reconstruct, like the nasal bone. Bioabsorbable implants like osteomesh is another advance, where essentially there is an implant which over a period of time allows the bone to regenerate in that area. Bioabsorbable implants, they tend to degrade after the fracture has healed through hydrolysis and promote the gradual transfer of functional forces to the healing bone while they are disintegrating. Osteomesh is one such implant that can be configured to fit in the area of your fracture, and over a period of time it promotes osteogenesis and allows new bone to form in that area while the implant itself is disintegrating. So if you follow these patients up over a couple of years, you would have formation of new bone in the area where you originally had a fracture. There is an excellent paper reviewing the use of bioresorbable implants by Dr. Ganga, and all those interested should definitely read this up. The seventh point I wanted to highlight was the need for a multidisciplinary approach, especially for a patient like this, who would also require a rhinoplasty. And sometimes for those who have a frontal bone fracture, you might even need to work in sync with a neurosurgeon rather than working in silo. In ophthalmos, following fracture repair is one of the commonest complications that you'd see in the hands of an orbital surgeon. And this is one lady who has a floor and a medial wall fracture. If you look at the post-op scan, there is an excellent correction in the fracture, but she still has some amount of enophthalmos. And this probably has to do with the fat atrophy that occurs due to trauma. And these are things that you tend to learn over a period of time, especially when you do post-op scanning over your patients as well. Another lesson that I learned along this path of treating fractures is when you, for instance, this patient with a floor and a medial wall fracture, we assumed that the zygoma component was possibly not very significant since there's not much displacement, and treated only the floor and the medial wall with a suboptimal outcome, as you see over here. So that defect in the zygoma between the zygomaticosphenoid bone is the gap over here, which is resulting in an increased orbital volume, is what also needed to be corrected in this kind of a patient. And one last situation that I'd like to share is this patient where we thought there was gross enophthalmos with the eyeball collapsing towards the maxillary sinus, all the walls of the orbit broken. And your immediate reaction is to post the patient for a fracture repair. But look at the rest of the scans in this patient. While the eyeball could not be moved clinically during examination, one of the reasons for that was not only the fracture, but it was a fragment that had actually gone inside the eyeball. This patient had an open globe injury with a bone fragment going right through the eyeball. He had a good vision, but he had to be counseled regarding this before taking the patient up for fracture repair. So it's a lesson that I'll never forget in my life. To summarize, I have spoken to you about the orbital fractures, the facial buttress, and the ways we classify orbital fractures, surgical planning, especially in cases who have entrapped muscle who require early care. I briefly spoke about hidden incisions that can give you an aesthetic outcome in orbital reconstruction. We discussed image guidance and the role of navigational systems. We spoke in brief about 3D printing and how it can help you give that extra boost of accuracy to your outcomes. Titanium is the implant of choice in most cases these days. We also discussed multidisciplinary approach with your maxillofacial and neurosurgeon, especially in panfacial trauma. We discussed about enophthalmos and why it occurs in most cases post-repair, and also about the lessons that we learned along the way, where careful examination of radiology is probably one of the most important things. The last but one slide, I'd like to invite all of you to a bonanza on complex cases in oculoplasty that we are hosting on 20th and 21st of March 2021. We have stellar faculty lineup for the conference, and I hope to see all of you there. Thank you so much.